Trauma care is a multidisciplinary event that happens from the EMS provider, rural, all the way to the surgeons and all the care providers in between.
You know, even across the aisle, we agree that public safety is the most important thing that government does. And trauma and EMS systems are the very basic level of actually saving lives. You may find yourself in an ambulance later today, and the time to make sure that ambulance is there later today is when we're doing public policy at the state level, long before anybody needs it.
Catastrophic injury does not discriminate. It affects people across all demographic categories and walks of life. Trauma systems are truly democratic and save lives regardless of social or economic status. Just like fire, police, and emergency medical systems, trauma systems should be a part of the public safety net. The absence of a coherent federal program to guide and fund the development and operation of trauma systems has placed the responsibility for this critical element of the public safety net directly on the shoulders of state governments.
With the absence of the federal program at the Health Resources and Services Administration, the American College of Surgeons has emerged in a leadership role in the development of trauma systems nationwide. It has been our privilege to work with trauma program managers and trauma program medical directors in more than 35 states.
Trauma centers are designated by the level of care they provide, with level 1 being the highest level of care. And each state does this a little bit differently, but they go down to level 2, 3, 4, and in a few states even a level 5 trauma center.
Trauma system development is in and of itself a bit of a complex system of care. We have shown without doubt over the last 40 years in this country that efficient trauma systems do save lives.
Trauma, injury, and death from injury is a leading cause of loss of life up to the age of 45 in this state. It also keeps more people out of work than any other medical condition in the state.
For legislators to fully understand what not only the immediate impact, but the downstream impact is in terms of funding and supporting and appropriately regulating trauma systems in a way that get the right patient to the right place. It's an important concept to help them understand.
State funding for trauma systems is highly variable, running from essentially zero to the tens of millions of dollars. The source of funding is also variable, depending upon the local political climate and the level of public support. Sustainable solutions include the use of general funds, the assignment of specific taxes on items such as tobacco, and the assignment of a portion of traffic fines. In our experience, funding strategies that utilize the general fund are more vulnerable to changes in political climate than solutions that specifically designate a funding source.
We spend an awful lot of time informing and working with our state legislators as well as our county commissioners and other local officials, because ultimately these are the individuals that have to make the policy decisions that will decide what resources are truly made available to the patients and victims of sudden accident and injury.
To get a big picture of how an ideal trauma system should run that improves the entire health of your entire region and all your constituents, you need to remove it from the local level a little bit and look at it from a more global picture. One area that legislators can help tremendously is doing a real needs assessment for how much money is needed in a trauma system.
One of the most significant innovations that we're experiencing right now and over the last couple of years is the concept of regionalization, and within that concept, the idea of using our allied healthcare resources in more non-traditional roles.
Community paramedicine is something that we're seeing a lot of and is allowing these highly skilled paramedics to do more. And a lot of it is focused on a rural community that maybe it takes a long time for people to get to the hospital, so they're doing things like in-home follow-ups, more education, diabetic checks, those kinds of things.
This is a pretty dynamic time for healthcare all through America and certainly in Minnesota as well. And so as we try to anticipate adapting to what the future might be, especially with the Affordable Care Act, some of the ways that we're beginning to think about that is by integrating EMS run information, their electronic records of their cases, into the Health Information Exchange system that's being set up through the Affordable Care Act.
When it comes to communicating the needs of those that provide EMS and medicine to legislators, I do think that there are times when those kinds of folks ought to be offering to legislators, come and ride in an ambulance for a shift and see what we really deal with and how things really go, and interface with the chaotic emergency room to really get a sense of the differences between the life and death kinds of things that ambulances often bring to an emergency room and the colds and flu that are dealt with in the emergency room because some folks don't have access to medical care except the emergency room.
The day-to-day capabilities of our EMS and trauma system and how well we handle those and incorporate our facility resources on the day-to-day component is exactly a reflection of where we will go and how we will be able to respond to the mass casualty or natural disaster situations that face us. But it all is built on a foundation of a quality system that functions in a quality manner on a day-to-day basis.